الله يحفظكم ويجزاكم كل خير إن شاء الله على هالتنظيم الرائع. طيب بسم الله الرحمن الرحيم. أنا نايف الحربي R6 Neurosurgery من كينج عبد العزيز ميديكال سيتي from National Garden رياض. اليوم إن شاء الله راح نتكلم على النيوروسيرجري overall. هذا راح يكون outline للتوبيك اللي نتكلم على إيش هو النيوروسيرجري وإيش هو بالضبط في الريزيدنسي بروجرام، إيش الفيلوشيبس available في النيوروسيرجري. And why would anyone choose neurosurgery? A common question is why the long 6 years in the residency. A few points regarding the myths and misconceptions about neurosurgery, the competition, the advantages and disadvantages of the local program, and what is the best training center. So, in summary, the neurosurgery residency program, it's a 6 years joint program, meaning that, and I'm speaking about Riyadh and Sharqiya and Jeddah, because they are honestly the main centers of training. They have joint program in the sense that you will rotate in all the tertiary centers in the area. You will handle basically any disease related to the CNS, the peripheral nervous system, the spinal column, from the surgical point of view. This would include trauma, congenital anomalies for pediatric, tumors, vascular disorders, infections, stroke, specifically if it's a hemorrhagic stroke, that would fall under your umbrella of expertise, and the degenerative disease of the spine. Another thing in regard to the spine, neurosurgery now are almost like taking over, for example, scoliosis, which used to be an orthopedic specialty. Specific examples of disease you'll encounter as a neurosurgery resident would include traumatic brain injury. The surgical point of view is from an epidural and subdural hematomas, brain AVMs and brain aneurysms. You will handle a lot of brain tumors. Specifically, the worst one is the GBM, craniosynostosis in the pediatric, where there's a premature closure of the skull sutures. What is your intervention? How do you expand? How do you reshape the cranial vault to give the patient a normal appearance and to avoid high ICP from this disease? You will encounter also epilepsy and Parkinson's disease, hydrocephalus, neural tube defects, specifically spina bifida, the herniated disc and radiculopathy of the spine, and even small cases like carpal tunnel syndrome. The possible fellowships in neurosurgery would encounter a lot. In neurosurgery, it's true, it is a subspecialty itself, but it's a vast sea of any possible diseases. You will encounter a lot of areas of neurosurgery where you would need more years to study them and to be a good neurosurgeon in that specific area. These would include vascular neurosurgery. Vascular neurosurgery nowadays, as a neurosurgeon, if you want to go to vascular neurosurgery, you'll have two options at your disposal. You can be a neurointerventionist and a neurosurgeon, vascular neurosurgeon at the same time. You can go with the functional neurosurgery. You'll deal with the epilepsy, Parkinson. You will do deep brain stimulation, hemispheric disconnection. Oncological neurosurgery, again, you'll deal with the tumors, skull-based neurosurgery, and this is the specialty that is giving the impression that neurosurgery has this very long OR time, hours, and in quotations mark, it has a bad morbid outcome, mainly because this is a very delicate specialty that requires a very delicate intervention and specific training in this area. Spinal neurosurgery, which again, you're competing with other specialties like the ortho. However, in neurosurgery, you have the privilege of tackling intradural tumors. So you are not only limited by the spinal column. No, you can go inside, you can have untethering of the cord, you can deal with spinal meningiomas, ependymomas, other diseases that within the spinal cord. Peripheral nerve surgery, this is the bloodless specialty of neurosurgery and doesn't have really the urgency of intervention. Pediatric neurosurgery, and this is an area of its own. You will be dealing with the congenital anomalies, the pediatric diseases, so it feels like a different specialty than the rest of the neurosurgery. Neuropsychiatric surgery, this is like a promising new area for neurosurgery. We'll deal with the refractory depression or refractory OCD. Some centers will include it in the functional neurosurgery. Another fellowship that is possible for you as a neurosurgeon is neurocritical care. This is maybe with the neurotrauma fellowship. You can be an intensivist and a neurosurgeon at the same time. Going to the question of why neurosurgery specifically, and I'm gonna be honest with you. I'm trying my best not to be biased in this talk, but if I was gonna answer this question, I would say, why not neurosurgery? To me, this specialty is encompassing all the things I am interested in. First of all, the neuroscience. If you are interested in neuroscience, specifically during your medical school, you're interested in the topics of neurology, of the topics of psychiatry, and you had this idea of going against the pathology directly. Neurosurgery is the specialty for you. It has a lot of hands-on exposure during the OR, and this will start since you are R1. Another point about the neurosurgery, it's adaptive to the technology, and it's in desperate need for technology. That's why there are a lot of researchers in this area, and it's a promising research. The neurosurgery, for example, is adapting since around 20 years the neuronavigation system. The concept is simple. You have the patient brain CT or brain MRI uploaded on a screen in the OR, and you have the sensor around the patient. And with your probe, whenever you are near the lesion, you can see it on the screen. The idea sounds simple, but it had made a huge advantage for neurosurgeons all over the world. Another advantage in the neurosurgery is you're not limited to a specific group of patients. You're not specifically for the adults or the pediatrics. You will see all kinds of patients from different populations. This will keep the specialty refreshing for you. You will see a lot of patients, a lot of diseases, and specifically if you are interested in the surgery, this is the specialty for you. Another point that I noted a lot of the medical students and interns interested in, they think that this specialty will give you the prestige that you are a neurosurgeon, you are dealing with the brain and all of that. But in reality, this does not translate to anything. The patient is entrusting you with his brain. This is his personality, his memory, his function, and above all, his life. So this should humble you as a physician, that this patient has trusted you with this. You have to do your maximum. There is no room for ego or for prestige or anything. Actually, even if you wanted to do that, there is no time for you to show off your specialty to any other people. You'll be mainly interested in the OR, mainly interested in your patients. So if you're interested just because you want neurosurgery for the name, this is absolutely not the specialty for you. And I noticed that some of the interested interns, they will have two plans. Like, I want neurosurgery and my plan B is cardiac surgery. This is a big no-no, and don't ever tell anyone that you have this plan, because this will show you as someone who's interested in the name, is not interested in the neuroscience behind it or the intervention that he can do, and just avoid it at all. Another point is regarding the private. This is a realistic aspiration for any neurosurgeon or any physician. You want to have stable financial situation. Neurosurgery specific fellowships and specific subspecialties have a very good financial outcome, specifically talking about the spine. In neurosurgery, the spine is considered to be the main specialty that will give you the financial reward. Other specialties are not like the spine exactly. The problem with the neurosurgery is that it's like a hidden specialty from us. I remember in medical school, we only had 2 lectures about the neurosurgery. It was brain tumor and traumatic brain injury. And that was it. We had no further exposure to neurosurgery per se. We had the neuroscience and neurology, but the neurosurgery was like a hidden specialty. We did not have the proper exposure to it. I only knew about it because I had an elective at the 5th year. I went there and they were very welcoming, and it felt like this is a specialty for me. And I would encourage everyone to have an elective before you start your internship. The problem with this point exactly is, even when you are a resident in neurosurgery, other people from other specialty don't have this exposure. So they will call you for any little thing about the brain. If it's a calcified meningioma that has been there for 10 years and it's not expected to go, they will call you for it. If it's a small aneurysm, 3 millimeter with no intervention in old age, they will call you the other services. They are panicking. They don't know what to do. They think it's gonna rupture. You are the guy for this. Going to the why the long 6 years. First of all, you are expected to be a very good meticulous anatomist. You have to know specifically the anatomy, the pure anatomy and the surgical anatomy. Once you start your surgery, you want to know what will encounter this step, what you should avoid in the next step. So it's like two different anatomies of the same organ. And you're expected to be a very good neuroradiologist. During the on-calls, the radiology department will be covered by a general radiologist. By definition, you should be better than a general radiologist. You have seen a lot of brain CTs, you have seen a lot of MRIs for the spine. You should be better than a general radiologist. You should not wait for the report. And even the ER sometimes will call you before the report. They're asking you to read the images. So, we said that you're going to be a neuroanatomist, you're going to be a neuroradiologist, and a neurointensivist. The problem is that in our country, we don't have a lot of neurointensivists specifically. We can have a neuro ICU, but no neurointensivist. And I've noticed this in the few tertiary centers in Riyadh. You are expected to be better than the general. This is your specialty, this is what you have seen, this is what you know. So the plan comes from you, not from the ICU. Specific cases like in subarachnoid hemorrhage, you are the one expected to put the protocol. They'll even ask you what is the exact blood pressure you want to maintain. This will comes from you. And even as a neurologist, you have to be a good neurologist. I'm not saying you'll be like someone who spent 5 years in neurology, but you should be a good neurologist to identify what is the issue you're facing, whether it's medical or surgical. This would explain why we have the 6 years. It is separated to 3 years of junior level and 3 years of senior level. Regarding the myths and misconceptions about neurosurgery, one of the frequent things I'm asked about is the OR long hours. And this differs by specialty, subspecialty, and by consultant, to be honest with you. A case will take 3 hours, for example, the consultant will take like 2 hours or 6 hours with another consultant. And it depends on the disease itself and the subspecialty per se. But on average, you are expected to have, if you have an OR neurosurgery that day, it should be around 3 to 4 hours. This is on average. I remember we had a case, a craniotomy for a depressed skull fracture that finished in 25 minutes. And another case that was the longest hour. It was 23 hours. And this was one time only. And the new trend in neurosurgery is to do it on 2 stages. You do the craniotomy and the drilling. You keep the patient intubated, send them in ICU. Then tomorrow you resume once you have reached the tumor. So the heroics of the long hours of a full day hours are something of the past. It's not encouraged nowadays because it will have the prolonged anesthesia itself will have a bad effect on the patient. Another point is some people are saying this is a more specialty. As we discussed earlier, that this specialty encompasses a lot of subspecialty beneath it. But in the end, you are dealing with the brain, you are dealing with a life or death situation. You're not saving a function, you're not improving something. No, you are at the last step. You are either saving this patient or he's dying. So once the stakes are high, of course, the reward's gonna be high and the risk will be high. So it is part of the specialty itself. And we don't really see it that often as people imagine. For example, if you have an epidural hematoma in a young patient, post-MVA, and he's coming with a GCS of 7, he's already intubated, fixed dilated, you take him immediately to the OR, you evacuate the hematoma, and 2 days the patient is discharged home. So it's not really as morbid as people believe. It actually has a good outcome. Specifically about neurosurgery, I noticed even myself before I applied to neurosurgery, there was a drop rate of around 21, as mentioned before from the head of the scientific committee. There is 21% of people who apply to neurosurgery, then they drop out of the local program. Some of them go outside, some of them change their specialty altogether. And this has to do with the applicant himself or herself. If you are choosing the specialty for the wrong reasons, definitely you will not be adaptive or comfortable with the neurosurgery. It's you have to have a very good reasons for choosing your surgery. Myself, I chose the neurosurgery directly because I liked neurosurgery, and by exclusion because I didn't feel comfortable with any other specialty. So this is like a future-proof plan, so you don't have this fear of dropping out of the program and wasting your years. So again, if you choose it for the right reasons, you will be in good hands and you will enjoy the neurosurgery. It's very rewarding. The euphoria you get from the OR is something else you'll never experience. Another thing is regarding the busy on-calls, and this differs based on the hospital. For example, National Guard Hospital is considered to be a tertiary center and hospital in Riyadh and a trauma center. So we have a lot of referrals, a lot of trauma cases as emergency, and at the same time, you are covering two hospitals. You're covering the pediatric hospital and the adult hospital. So yeah, this is gonna be a very busy on-call if you are rotating in National Guard. However, if you're rotating in King Faisal Hospital, for example, or King Fahd Medical City, or in Bin Sultan Medical City, you are not expected to have a busy on-call as in National Guard. But be prepared, because whenever the ER is calling you for emergency in neurosurgery, this is going to be something very serious. Another thing regarding to the social life. So this is something that you yourself will decide. How much social life you are expecting, how much you are willing to give the specialty to be a good neurosurgeon. We already know that it's 6 years and we are expected to do a lot of things and to learn a lot of things and be able to do a lot of procedures. So you have to compromise. And I'm going to be honest with you, it's not like the other specialty. No, you will not have the luxury of going every weekend. No, some of the weekends you will be on call. This weekend, the next weekend you're not on call. You will have this selective quality time. You'll not be able to waste your time like you used to do before. Again, it depends on your lifestyle. No one can tell you will have a huge impact on your social life without knowing your exact social life. But it's gonna be limited, and you will have a selective time for your. It's gonna be quality time. You will not waste your time going out every weekend. For the competition, it seemed to be spiking the last years. This is from the Saudi Commission for Health Specialties. I think in Riyadh it's 78. Seems to be above the competition, above the average of the competition. But the problem with it is that all of those who are interested in neurosurgery will have a good resume, will have a good CV, good scores, and they will compete with you even beyond the nomination for the acceptance in this specific center. In Riyadh, for example, the average of acceptance is 5 to 8. Each center's averaging 1 or 2 residents per year. But to be on the safe side, I spoke with the new residents in the program, and this seemed to be their average GPAs 4 and 4 above. Their SMLA scores around 80. Where they excelled is in their CV. This added a lot of points to them, and all of their internship electives were in neurosurgery. They had the chance of going to different centers to maximize their chances of acceptance in neurosurgery in all centers. And I'm going to be brutally honest and saying that if you start your internship and you don't know your specialty, I'm sorry, but you are already at disadvantage compared to other people. They already know their specialty, and they're working on the next step in their plan. They want to maximize their chances of acceptance in other centers. Neurosurgery have workshops, and it's very good to have it in your CV. the last 3 days, we had the annual SANS, Saudi Arabian Neurological Society meeting. Of course, with the COVID, the workshops are limited, but there were online workshops. You can have the basic drilling workshops, the basic operative skills, the BOSS course. This will also help you in your resume. And we had the boot camp for neurosurgery. We had medical students competition. You can present your posters or research. Having won or participated in those conferences and events will definitely boost your chances of acceptance. Regarding the local program, it's a well-structured program. Basically, you have around 18 months. You have a few off-service rotation. You will rotate in GS, ICU, neurology, neuropathology, neuroradiology, and elective. This elective can be clinical or non-clinical depending on your choice. But you rotate in each of these specialties. Each one of them is 3 months. After that, it's going to be purely neurosurgery. And it's not like you will spend the first year or 2 years off surface. No, this is intertwined into your 3 years of junior level. So far, the local program graduated 50 neurosurgeons. 39 of them were males and 11 females. Currently, we have yes.
آسف جدا على المقاطعة، بس بخصوص الوقت يعني تقريبا الوقت انتهى.
Sure.
ما أدري إذا باقي.
We'll speed it up. I think this is the one before the last. Yes, this is the last. So the local program is good in terms of the current resident. We have 128, 80 males and 48 females. We have the national weekly activity. It's a joint program. Again, you will rotate on all other hospitals. We don't have a lot of numbers, so that better for you as a resident. You will be exposed to a lot of the surgeries. As this junior will have the priority in doing the opening and the closure. Just a question about what's the best training center. This is difficult to answer, but the good thing is the joint program. You'll have to make the decision. You will rotate in all other centers, and the fellowship will depend on your exposure in these hospitals, whether you want to continue with them or not. And with that, I conclude my talk. If there are any questions.